Thank you, George, and good afternoon, everyone. So, first of all, if you come to this meeting and you see these cases, you think that the entire world doing rotational atherectomy. So let me tell you, this here is anomaly. It's a good anomaly. And I actually congratulate Dr. Sharma and Kini for actually pivoting the rotational atherectomy, which I think should be done in much more of the cases. But if you have a clue how many of the calcified lesions are being treated with atherectomy devices versus what I'm asked to talk about, non-atherectomy devices, the ratio is probably 10 to 90. And the question is, why is that? Why we're not using atherectomy like what you're seeing here in this course, every other case? And the reason is that there are some complications. There is some complexity, although I don't buy that because DK crush is much more complex to do an atherectomy. But no one wants to see a no reflow phenomenon. No one wants to see perforations. No one wants to see bed dissections. And as a result of that, people shy away. They think that they can do it without it. So my goal is actually to talk about the others. And what are the others? Non-compliant high-pressure balloons, scoring balloons, cutting balloons, and lithotripsy. I took laser out of this because laser is still atherectomy for those who want to. So these are very simple things. And I would say the lithotripsy just entered into the market. But we really have to change the way that we are thinking. Now that we have all those devices and we're supposed to be better in atherectomy and with the RotaPro and the CSI system, we really have to go to some algorithm. Now, George showed you a very complex algorithm and it took about 3-4 minutes to go over that. This is a simpler one. And the question is very simple. Can you pass a microcatheter? And I think he did mention that. But you can see that if you can do a stepwise inflation, escalating non-compliant balloon size. You can use scoring or cutting balloon. And then, only then, if it doesn't work, the new kid in the block, you can use IVL. And what I'll try to show you some data on IVL because it's not been covered much in this meeting. Now, this is much more complex algorithm. This was proposed by Dr. Schlomfitz from St. Just across the island here. But again, what I'd like to take you, he does everything by OCT, which is also very important actually to understand what is the imaging tells you and can the imaging guide you which device you would use. But if I'll just take you to the bottom of this slide, you can see here that on the very left, you see if it's a deep calcium you can use a scoring balloon or cutting balloon. If you have a calcium fracture on OCT, you can use IVL. So there is one group that would use rotational atherectomy or orbital atherectomy. And these are when you have traditional atherectomy that's done in nodular calcium. When you have a superficial, it used to be just for atherectomy devices, but now we have data also that lithotripsy can work. And if it's a deep calcium, there's basically no role for atherectomy devices. You can basically use non-compliant scoring balloon or cutting balloon. And again, this is just an example of what you're seeing by imaging and what you can get with balloon that you try to get in a with a non-compliant balloon in a calcified lesion that you cannot open it. So let's discuss about lithotripsy because this is really the new kid in the block. It is approved and there is also reimbursement, well, not complete, but it does help. So what is the lithotripsy? It's basically based on acoustic pressure waves that fracture the calcium. And these are traveling through the tissue with an effective pressure of roughly about 50 atmosphere and fracture both superficial and deep calcium. Now, if indeed this is working, then this system will offer you a very safe procedure, as was shown in all the trials so far, with no perforations, no dissections, no losing of flow. And it does give you assurances that you, in most cases, will be able to get the desired result. And it comes in different diameters and different catheters. We've been using it excessively in the periphery, which that's how it started. But when you look in coronary intervention of lithotripsy, you see a very good effect in enlarging the lumen after creating those fractures to a lumen area that starts from 2.98 on a heavy calcified artery all the way to a lumen of 8.15. The pivotal trial that granted approval by FDA was called Disrupt CAD3. Again, it was a registry. There were rolling patients and 384 patients that were in the intention to treat. And what was presented was only 30 days follow-up, which was enough to grant that approval. Now, what was the major endpoints? There was a primary safety endpoint, which was freedom from MACE at 30 days, cardiac death, myocardial infarction, target vessel revascularization. And there was primary effectiveness of the procedure, which was defined as successful stent delivery with residual stenosis less than 50% and without in-hospital MACE. And then there was all the secondary endpoints. So this is the study algorithm. Overall, there were 431 patients in the study with the rolling and the intention to treat. These are the characteristics of the patient. The procedure time was relatively adequate to a calcified lesion, nearly 60 minutes. The number of IVL catheters was 1.2, IVL pulses 68.8, and the number of stents that were used was 1.3 with a very good stent delivery. So this is the angiographic outcome. You can see pre-procedure, post-IVL, and post-stenting. So you're achieving a very nice lumen. And in terms of angiographic complications, post-IVL, you can see that they were very, very small. There was zero perforation, zero abrupt closure, 0.6% slow flow, and zero no reflow phenomenon. And final post-stent was, again, no issues with any complications. So as a matter of fact, it seems to be very safe and also effective device to use. These are the primary safety endpoints, which worked through a performance goal. We wanted to have a randomized trial, but there was no randomized trial. But it did met the primary safety endpoints as shown here, and also the primary effectiveness endpoint. And these are the in-hospital 30 days MACE, which were very low overall, 7% at in-hospital and 7.8% at 30 days. And you can see here, very low event rate. These are the secondary endpoint with composite success rates of roughly around the 95%. It is very good for a treatment which is not atherectomy based, and it doesn't take much time and much pain to do it. These are some peri-procedural MI. They're also relatively very low. We see or tend to see more distal embolizations with atherectomy devices. And overall target lesion revascularization at 30 days was 7.6%, all revascularization 2.6%, and stent thrombosis only in 0.8%. There was an OCT sub-study, again, demonstrating that there is really a breakout and fractures of the calcium after using the acoustic waves. And overall, they summarized that they confirmed by OCT safety of the coronary IVL with no severe angiographic complication at the end of the procedure. And it's demonstrated longitudinal and circumferential calcium fractures, and MSA area stenosis and stent expansion outcome were excellent regardless of calcium fracture visualization by OCT. And this may represent a limitation of OCT to detect subtle microfractures in calcified plaque. But overall, I think we have to recognize we need to learn exactly how to use it. But if I have to make a prediction on this podium today, I would say that we would see much more of those devices being treated calcified lesions. It's not going to be on the expense necessarily of rotational atherectomy. We'll continue to use that. I'm sure that Dr. Sharma will continue to use it heavily. But for the other centers, they will use much more this lithotripsy because these are very promising devices. And I'll stop here because of the time. But again, when you go to the website you'll see many other cases that shows and demonstrated the performance of this one, like in this calcified lesion, This is a very tight calcified lesions that has been treated nicely with the acoustic balloon as shown here, and this is after the last balloon inflation, and very good result. So my take-home message, there is still a role for the non-atherectomy devices. If you want to see how does it working versus the atherectomy devices, we will need randomized clinical trials. And I'm sure someone would do those trials against atherectomy, whatever it is, rotational or orbital, and will prove or not prove whether this device is safer and more effective. Thank you very much.